Hello, I'm Vikas Malik, one of the ENT consultants working in the Trust. I'm lead for education in the department as well as lead for the department of induction. I'm here to share with you the practice which we have adopted in our department, especially regarding the induction and how we use simulation to enhance the training of the trainees as well as to make sure that we deliver a high quality and a safe patient care. I cannot emphasize, and I'm sure you'll all agree with this, how important the induction of junior doctors is when they start in the department. Often they've not done the specialty before, or if they've done it, it's been a while back. And they have a long day. They go through several slides, different topics, hundreds of slides, and it's a very long, tiring day where it becomes difficult to retain the information. So how we've changed our department induction is we've divided this into 4 different parts. The first part is we take them around the hospital and the department, show them the places around which are relevant to them, theatres, wards, treatment rooms, secretary's office, their office, etc. Then we go through the policies in the department, do kind of do's and don'ts in the department, and who to contact, where the people would be, and how they can, if they are in trouble, if they want to discuss something, how to approach different people, who will be the right person. Then we go through different slides, which are clinical pictures rather than text, and videos about the common ENT conditions which they'll encounter throughout the posting in the next few months. And the last bit is the most interesting bit, which is we bring them to the skills lab here because we have an excellent skills lab in our hospital. We're fortunate, and we use the simulators to have hands-on training, which not only enhances the confidence, but eventually it all reflects in the safety and the quality of the patient care we provide consistently. I'll show you briefly what sort of simulators we have, and you'll appreciate that this will kind of give more confidence to the juniors when they start in the department. This is an ear simulator, so they learn how to examine the ear, as well as there are 10 different pathologies which we can show them and they identify. We can have different kind of foreign bodies which we can put in the ear, and they have to retrieve it safely. Also, this comes with an interesting system where we can turn the monitor on, and if the technique of examination isn't right, then it raises an alarm and the patient is in pain. We also go through, once again, consolidate their understanding of tuning fork test, which is very important because if someone presents with a sudden sensorineural hearing loss, that's a medical emergency and needs immediate treatment with steroids. So they kind of learn to differentiate between a conductive from a sensorineural hearing loss in an emergency situation. Coming on to nosebleeds, which is again one of the commonest emergencies they'll come across. So we have this lovely model where we can make it bleed from 4 different common points, anatomical points in the nose, and they have to correctly identify where it's bleeding from and cauterize it. When they touch that spot, a green light comes up. That means they are hitting the right spot. As well as we can use the model to pack the nose with different kind of packs, which is very, very useful to them. We also use this model where we put the foreign body in the nostril, and they have to retrieve it without causing any trauma. So that's again another common kind of emergency which they'll come across. For more senior trainees like registrars who come, so we have a model where they do an emergency tracheostomy and a cricothyroidotomy, so that they're familiar with the airway, emergency airway management at their level. We won't expect our really junior foundation year or core surgical trainees to do this. It's mainly for registrars, this particular bit. But of course it's there. If anybody wants to try it, they all get a go at it. Another important procedure which we expect our juniors to do is to do a nasal endoscopy as well as flexible nasal endoscopy to examine the larynx and the pharynx. And we have a stacker with the camera and an endoscope and a model, so where they can actually pass the camera in, learn how to pass it, identify different kind of landmarks, and practice fiber optic laryngopharyngeal examination and nasal endoscopic examination. Another really important part of ENT job is to be able to look after tracheostomies. And the first and foremost thing is to differentiate between a laryngectomy patient from a tracheostomy patient, how to manage a patient who has a tracheostomy in place, who can't breathe, who has a blocked tracheal tube, for instance. So often, very junior trainees like foundation years, GP trainees, or core trainees may not have ever seen a tracheostomy tube. So we have all the varieties of tracheostomy tubes: cuffed, uncuffed, long flange, normal tubes, pediatrics, fenestrated, so they kind of they can see all the tubes. And then we have a scenario where we have a patient who cannot breathe because his tube is blocked, and they have to identify the problem, unblock the tube, take the inner tube out, and so they just take the inner tube out to relieve the blockage and change the tube. At the same time, we also introduce the tracheal dilators, which are for emergency, to keep the stoma patent in case the tracheostomy tube falls out. And we have different algorithms which are always there, and this really gives them lots of confidence to be able to simply take the inner tube out, which can save the life of the patient. So these all simulators are always available, and I cannot thank our simulation skills, the skills center team, thank enough, because they always help us out, and these simulators are always available for any of the trainees to come along, and we encourage them to have a buddy system where a very junior trainee may come with someone slightly senior, or if a consultant has free time or registrar has free time, they come along with them and they can practice as many times as they want. We have audited our results of this induction to see how confident trainees feel when they join the department before going through this, where they've just sat and listened to our talks, and once they've done practical sessions. And it's no surprise, it shows a significant difference where they feel much more confident. We have presented this in several meetings. In fact, one of our trainees won the best award in a national meeting, and we've also presented this in annual Medical Educators Conference in Glasgow. We're also using simulation more and more in our training. Yesterday in an audit day, we had a simulation-based training for all the ENT and emergency theatre staff and the junior doctors on pediatric bronchoscopy, because that's very rare. But if you don't know how to assemble the kit and how to do it, which you can easily forget because you may just do it maybe once in a year or once in a few years, then that could be fatal, and you can actually lose the child. So we had that session yesterday, which was very useful, not only for our doctors, also for the nursing staff. This part of induction is also reflected in the trainee surveys and GMC survey, as well as during the deanery visit. This was highlighted as a really good practice, and it's definitely worth it, because at the end of the day, it's all about the patient safety and delivering a high quality care. We are also now planning to start in situ sims, which we're planning to kind of start from April onwards, and that'll bring another dimension and improve the training which we provide.